Okay, can everybody see that screen? All right, there we are. Good afternoon, everyone. I am so excited to be invited to share this presentation with all of you. And I am so appreciative of Philly Flight for organizing this conference on anti-Blackness. And what I'm going to be sharing is anti-Blackness and how it shows up in medicine. So the objectives for today are to describe how anti-Blackness and systems of privilege impact health and lead to health disparities, to discuss the need to challenge the healthcare system. Oops, sorry about that. To challenge the healthcare system to identify and address racism within and transform care to reduce health disparities, and also to list ways to heal from racial trauma. So first I want to just make sure that we're all on the same page about definitions. Racism and anti-Blackness. So race is a social construct. Oftentimes people think about it as a biological construct, but it's not. It's a social construct, man-made, and it's a concept which signifies and symbolizes social conflicts and interests by referring to different types of human bodies. And racism is the belief that race is the primary determinant of human traits and capacities, and that racial differences produce an inherent superiority of a particular race. And that's where the term white supremacy comes in. It's the idea that white persons are inherently superior, the way they do things, their traits, their bodies, and so forth. But racism is a system. I don't know why I'm doing that. Racism is a system. It's not, as we tend to think about it, just an individual character flaw or a personal moral failing, and not a psychiatric illness. It's a system that consists of structures, policies, practices, and norms that structure opportunity and assign value based on skin color, and in unfairly disadvantages some individuals and communities. But even more profoundly and less discussed, this system of racism undermines the realization of the full potential of our whole society because of the waste of human resources. Dr. Kamara Jones developed a framework to describe 3 levels of racism. So as we go through the talk, I want us to think about anti-Blackness along these 3 levels. So there's institutionalized, which is more structural racism. There's personally mediated, which oftentimes that's where people focus on the interpersonal level, and then internalized. And that is when people who are being oppressed internalize that racism. So let's start with institutionalized racism. It's defined as differential access to goods, services, and opportunities of the society based on race. It can be normative, sometimes even legalized, and it's structure. So it's codified in our institutions of custom, practice, and law. Personal mediated, that's defined as prejudice and discrimination. Prejudice is the differential assumptions about abilities, motives, and intentions of others according to their race. And discrimination means differential actions toward others according to their race. And this can be intentional or unintentional, acts of commission or omission. Some ways that it shows up are lack of respect, so poor or no service, failure to communicate options, suspicion, So a shopkeeper's vigilance, where they might follow a person of color around a store. Everyday avoidance, including crossing the street when you see someone of a particular race, purse clutching, standing when there are empty seats on public transportation so as to put more space between you and that person. Devaluation, so that can show up at surprise at competence, stifling of that person's aspirations, trying to keep them at a lower position. Scapegoating, that shows up oftentimes, we see it in the news where a person blames a Black man for murder or doing anything that they've done themselves, but using that stereotype and relying on people's racist beliefs. Dehumanization, we see that in police brutality, sterilization abuse, where women are not consented or pushed into sterilization, and hate crimes. So we're all familiar with the terms racism and racist. Why do we need to call it anti-Blackness? Why is there a need to point that out? I love this image. This was from a New York Times article written shortly after the George Floyd incident by a professor who wrote an opinion article. And the title was "Call It What It Is, Anti-Blackness. When Black people are killed by the police, racism isn't the right word." She goes on to say the word racism is everywhere. It's used to explain all the things that cause African Americans suffering and death in access to health care, food, housing, and jobs, or a police bullet, baton, or knee. But racism fails to fully capture what Black people in this country are facing. And the right term is anti-Blackness, and that's Dr. Tiana Ross. There are so many other factors that fall into the racism that is felt and caused in this country against Black people historically and to this present day. And so when we use terms like people of color or just blanket statements like racism pertaining to people of color, it doesn't fully capture the experience of Black people. And other people of color may have different experiences. Asians experience racism, but it may look different than the experience of Black people. So then let's talk about anti-Black racism or anti-Blackness. Anti-Blackness strips Blackness of value, so it dehumanizes, and it systematically marginalizes Black people. You see this in overt racism, and society also associates politically incorrect comments with overt racism, right? We can point to overt statements and say that's racist. But beneath that, there's also covert structural and systemic racism, which predetermines the socioeconomic status of Blacks in this country and is held in place by anti-Black policies, institutions, and ideologies. And anti-Blackness is also the disregard for anti-Black institutions and policies. This disregard is the product of class, race, and or gender privilege certain individuals experience due to anti-Black institutions and policies. So how does anti-Blackness show up in health? Well, very commonly we talk about the social determinants of health and how education or lack thereof, employment, access to food, housing, and issues of safety in the communities all contribute to the health of the persons in that community. And that's important to note as far as how different populations in a community are treated. But these factors are distributed unfairly and unjustly, and they contribute to racial disparities in health. But it's important to note and to go further than just naming those social determinants and realize that racism is a root cause of these health inequities and disparities. So addressing the social determinants of health without addressing racism is not likely to mitigate these inequities, and it actually may further perpetuate and worsen existing disparities. Additionally, healthcare alone will not eliminate these disparities and achieve health equity. Structural racism is an ongoing problem that persists across multiple sectors. And because of that, in order to advance health equity, solutions must include multi-sectoral efforts and must take into account and challenge the social, political, and historical context of racism in this country. But let's concentrate today on anti-Blackness in medicine and how that shows up. Well, we know that the U.S. population is about 13.4% Black, and according to the American Association of Medical Colleges report in 2018, among active physicians, 56.2% identified as white, 17.1% identified as Asian, 5.8% identified as Hispanic, and 5% identified as Black or African American. And then there were 13.7% that were unknown. But if you think about that, if the population is 13.4%, but in our medical profession, it's only 5%, we need to increase those numbers. But in fact, we've noticed that there's been a decline in the number of African American male matriculates in U.S. medical schools from 1978 to 2014. And Black men make up just 2% of male full-time faculty at MD granting institutions. Failure to confront racism within the medical profession not only has implications for how many Black doctors we have, but that in turn has implications for the patients that we serve. Studies have shown that Black infants continue to die at higher rates, Black children get less needed care, and Black adults receive poorer quality care than their white counterparts. Anti-Blackness in medical research is something that's known historically and even to today. One abuse we saw with the HeLa cells, very famously portrayed in a movie recently, that were taken from Henrietta Lacks' body without her consent, and that violated her human right to have ownership of her body. And we have to understand that historically, African Americans in this country were enslaved without rights to themselves and treated as property. And so that sentiment carried on throughout the years, and it's something to be recognized and addressed. In the Tuskegee experiments, Black men who had syphilis were not informed of their status and did not receive treatment. They wanted to study the long-term effects of syphilis, so they just withheld treatment from the men. In obstetrics and gynecology, the so-called father of modern psychology, Dr. Sims, developed the vaginal speculum that we still use today, and it was developed through horrific surgeries performed on enslaved Black women without anesthesia because he didn't experience pain the same way as white women. Angela Steine conducted an investigation of the history of race science in her book Superior, and she warned medical researchers that they needed to have a clear understanding of what they mean when they measure race in clinical trials, because they could be perpetuating biases in medical sciences by attributing race to biological aspects and saying that biological differences are because of race and skin color. Black Americans are still underrepresented in clinical trials, which is a problem, but is also related to a fear of participating in medical research because of situations that we saw, like in Tuskegee experiments, right? So Harriet Washington, author of Medical Apartheid, which is a fascinating book, says that this fear of participating in research is often dismissed as paranoia, but it should be taken as a legitimate concern based on 400 years of abuse. And it's something that in medicine we need to address and acknowledge and rectify. And how about in medical care? How does anti-Blackness show up? Well, anti-Black racial biases can either be consciously held, so someone is aware of their own biases, or unconsciously held. In the book Just Medicine, another excellent book, Dana Bowen Matthews explores the idea that unconscious biases held by health providers might explain racial disparities in health. Now, few physicians, just like in the general public, admit to harboring negative attitudes about any particular racial group. If you survey physicians at large, they will say, no, I don't harbor any negative attitudes about different racial groups. I treat all my patients the same. I've taken an oath, right? So physicians' explicit racial biases can't account for the disparities in health. And if physicians' choices around which treatments to prescribe and what care to offer are harming their Black patients, it's not likely that they're doing it with intention. And it's not likely that they're aware even of their beliefs about Black people that negatively impact the way they practice medicine. And this can affect the quality of health care, and it ends up differing by race when we look at it. So in a 2005 report from the Institute of Medicine, which is now known as the National Academy of Medicine, they found that poverty or lower socioeconomic status cannot account for the fact that Black people are sicker and have shorter lifespans than their white counterparts. Racial and ethnic minorities receive lower quality health care, even when insurance, status, income, age, and severity of conditions are comparable. I'm going to read that again, because I think it's important to take note. Oftentimes when people are talking about disparities, they think, well, surely there's a disparity, right? Because there are more Black neighborhoods suffering from poverty, or they have more severe conditions, diabetes and hypertension. But this study showed that racial and ethnic minorities receive lower quality health care, even when all those other factors are comparable. People of color are less likely than white persons to be given appropriate cardiac care, to receive kidney dialysis or transplants, and to receive the best treatments for stroke, cancer, or AIDS. The report calls this an uncomfortable reality that some people in the United States are more likely to die from cancer, heart disease, and diabetes simply because of their race or ethnicity, not just because they lack access to health care. But because providers are less likely to deliver effective treatments, even after controlling for a class, health behaviors, comorbidities, and access to insurance and health care services. And we see this not just in this report, but in a multitude of studies. It's repeated over and over again. For instance, one study of 400 hospitals found that Black patients with heart disease received older, cheaper, and more conservative treatments. And Black patients were less likely to receive coronary bypass operations and angiography. After surgery, Black patients are discharged earlier from the hospital than white patients. Just that it's earlier, but it's at a stage when discharge is inappropriate. Black women are less likely to receive radiation therapy in conjunction with a mastectomy. And in fact, they're also less likely to receive mastectomies. Black patients are more likely to receive less desirable treatments. And the rates at which Black patients have their limbs amputated is higher than those for white patients. While I was preparing for this webinar, I did a poll of some family and friends, and I actually had one friend talk about a situation where a loved one was only offered amputation for a problem that they had, a vascular problem, and no other options. And the family even pushed to try and find further options, and they had to go out of state to find physicians who would be willing to work with them and save this family member's limb. And as a result, she was a baby at the time, and now she's an adult and has full use of all of her limbs. But if that family had not persisted, her life would have been very different. Inadequate pain management is another area where we have seen in research and in reality that there's a disparity. So white medical students and residents falsely believe that the Black body is biologically different from the white body. So some examples were that they thought that Black people have thicker skin than white people, or that the blood of Black people coagulates faster than white people. And these false beliefs are associated with the perception that Black people feel less pain than white people do. And the result of that is inadequate treatment recommendations for Black patients' pain. Another way in which pain medication is withheld is due to negative stereotyping or unconscious bias. A study by the American Medical Association's Journal of Ethics found that African American patients and Hispanic patients were less likely than white patients to receive any pain medication. And if they were given medication, it was at lower doses. And the reason was due to a racial stereotype that Black patients and Hispanic patients would misuse the painkillers. And what the same study also found out, that in actuality, white patients were more likely to misuse prescriptions of opioids. And currently, we're seeing what some are calling a double pandemic, right? And that is with the devastation that COVID-19 has caused in this country, along with the racism that persists. Dr. Thomas Tsai, a professor at Harvard School of Public Health, said pandemics expose the inequalities in our healthcare system, and we have definitely been seeing this occur. Black Americans are infected with COVID-19 at nearly 3 times the rate of white Americans, according to a new document from the National Urban League. And this report is called The State of Black America, and it's based on data from Johns Hopkins University. It goes on to state that the infection rate for Blacks is 62 per 10,000, compared with 23 per 10,000 for whites. And Black Americans are twice as likely to die from the virus. And yet, there are still disparities in testing in Black neighborhoods. So not only are they getting hit the hardest, but they're also not getting tested. Next thing I want to talk about is a term called are interlocking, as the members of the Combahee River Collective pointed out in their Black Feminist Statement of 1977. More recently, there has been a rise in the discussion of intersectionality, which speaks to this phenomenon. It's defined as the interconnected nature of social categorizations such as race, class, and gender as they apply to a given individual or group, regarded as creating overlapping and interdependent systems of discrimination or disadvantage. And this term was coined by scholar Kimberly Williams Crenshaw in 1989 to help explain the oppression of Black women. Because we know historically, women have been oppressed, right, in our society. But Black women have had a double oppression, if you will. And that has caused contention in feminist circles. For instance, in fighting for the right to vote. The white women who were fighting for the right to vote did not want to talk about lynching or other issues that were affecting the Black community. They just wanted to focus on issues that they felt were important to them. Whereas Black women, lynching was incredibly important. And they wanted that to be a part of the conversation. And so all throughout history and even today, there is a struggle when dealing with the issues of oppression with Black women. You cannot just deal with issues of race versus issues of gender. Those things need to be taken into consideration together because they overlap, they're interdependent, and we need to recognize, acknowledge, and address those issues as such. So how does that show up in healthcare? There's a term known as weathering, which is used to describe how constant stress of racism actually may lead to premature biological aging and poor health outcomes for Black people. And we know that chronic stress has negative impact on health. Stress is your body's natural response to perceived danger, and it's meant to be helpful. But when you experience stress, your hypothalamus in your brain prompts your adrenal glands to release hormones like adrenaline and cortisol. And those are good for emergencies, right? We want those. But when it's chronically elevated, it can affect your bodily functions, like increase your blood pressure, quicken your heart rate. And these are all part of the fight or flight response, right? But if it's constantly active, that chronic stress has a negative effect. And so Dr. Adrienne Geronimus coined the term weathering to describe how this chronic stress of racism can lead to disproportionately high death rates from chronic conditions like heart disease, stroke, and diabetes. And in particular, one area that Dr. Geronimus looked at was pregnancy and the effect on pregnancy. And she started out looking at Black teens and white teens. And she found that over the course of the years, as Black teens turned into women and got older, their morbidity and mortality increased. And it demonstrated that over the years, the constant stress increased their risk. And this was not seen in the white persons. And even today, there's a lot of discussion about how Black women face higher maternal mortality rates. They are 3 times more likely to die than white women overall. And in some places, it goes up to 12 times. So there's definitely something going on. And it's not biological differences between Black and white women. It's because of the stress of racism. We also have to think about intersectionality in care of Black, trans, and non-binary people. They experience higher rates of violence and harm in our society, but then they also face high rates of racism and transphobia when they come for medical care. And studies have even shown that many trans and non-binary folk will even opt out of care rather than face the prejudice and discrimination they would find within healthcare. One thing I really wanted to address today also is systems of privilege. Oftentimes we focus on the systems of oppression and their effects and impact on Black people in this country, and that is very important. But we have to also acknowledge the role of privilege in continuing to uphold racism and its impact in this country. So this definition of racism, really points this out. It says racism is a system of structuring opportunity and assigning value based on appearance that unfairly disadvantages some individuals and unfairly advantages other individuals. Medical professionals are increasingly aware of how social determinants of health lead to health disparities. However, white physicians seldom ask how their own racial privilege reinforces a white supremacist culture and what impact this may have on their patients' health. And white privilege is prevalent, but it's rarely discussed. And our medical system favors both the white physician and the white patient, and we need to address this. There's a very famous idea that was put forth by sociologist Peggy McIntosh in the 1980s, and she talked about this idea of an invisible knapsack of unearned white privilege as it relates to oppression of Black people in this country. So she noted that when she was looking at the dynamics, there were some conditions that worked systematically to over-empower certain groups while disadvantaging other groups. And that privilege, that power conferred dominance just based on one's race or sex. She said, I have come to see white privilege as an individual package of unearned assets that I can count on cashing in each day, but about which I was meant to remain oblivious. White privilege is like an invisible, weightless knapsack of special provisions, maps, passports, code books, visas, clothes, tools, and blank checks. Things that she could cash in on whenever she needed them. I'm just going to read a few of the ideas that she came across, and I want those who are white to think about their own privilege in whatever capacity, in their work, in their community, and if any of these might get you to think about those things, and then those who are non-white to also consider what these statements mean for you.
For instance, number one is I can, if I wish, arrange to be in the company of people of my race most of the time. Number two, I can avoid spending time with people whom I was trained to mistrust and who have learned to mistrust my kind or me. If I should need to move, I can be pretty sure of renting or purchasing housing in an area which I can afford and in which I would want to live. And I can be pretty sure that my neighbors in this location will be neutral or even pleasant to me. I can go shopping alone most of the time, pretty well assured that I will not be followed or harassed. I can turn on the television or open the front page of the paper and see people of my race widely represented. When I am told our national heritage or our civilization, I'm shown people of my color made it what it is. I can be sure that my children will be given curricular materials that testify to the existence of their race. If I want to, I can be pretty sure of finding a publisher for this piece on white privilege. I can be pretty sure of having my voice heard in a group in which I am the only member of my race. That's just a brief example of all of the privileges that she came up with. I believe the list is about 50. But then I also came across a more recent article that talked about white privilege in medicine. And our medical system is structured, as I said, to favor white physicians and white patients, but also we are trained to ignore that system, right, that structure. Most white doctors do not think race affects them or their clinical decisions, and are taught to ignore their own racial privilege in favor of a meritocratic social myth, this a myth that our American society is built on, that if you work hard enough, you can achieve what you want, just based on merit. However, multiple studies demonstrate the existence of racial bias among physicians and its negative implications for patient care. And part of that privilege is that white people can ignore racism. They can choose to acknowledge it and confront it. And what is our hope is that more white physicians, nurses, and other care providers will begin to choose to acknowledge and confront it. Dr. Beverly Daniel Tatum has a book that's been out also since the 80s, Why Are All the Black Kids Sitting Together in the Cafeteria, and Other Conversations About Race, which is a great book just to read about race in general. But one statement that she has made is that it's important to understand that the system of advantage, or the system of privilege, is perpetuated when we do not acknowledge its existence. So we can't just simply ignore it and hope that racism will go away. We have to acknowledge and challenge the system of privilege that exists in medicine. And one way to do that is for white healthcare providers to begin to assess and reflect on themselves and the system as a whole. Dr. Max Romano set out to catalog some of the ways he has accrued unearned privilege in his medical training as a white male. And so he took Peggy McIntosh's Invisible Knapsack and did his own about white privilege in medicine. And I thought it was very profound to read. So I'm gonna read some to you. I have been taught since an early age that people of my own race can become doctors. Throughout my education, I could succeed academically without people questioning whether my accomplishments were attributable to affirmative action or my own abilities. And just think as we go through these that this cannot be said for a lot of African Americans who have gone through medical training, right? During college and medical school, I never struggled to find professors and academic role models who shared my race. When I applied to medical school, I could choose from many elite institutions that were founded to train inexperienced doctors of my race by practicing medicine on urban and poor people of color. I am reminded daily that my medical knowledge is based on the discoveries made by people who look like me, without being reminded that some of the most painful discoveries were made through inhumane and non-consensual experiments.
Dr. Peterson, your sound cut out for a second.
Because of my race. I can criticize medical institutions without being cast as a cultural outsider. I can name racism in my professional workspace and not be accused of being angry, potentially violent, or excessively emotional. When patients tell me they are glad to have a white doctor, I'm not personally threatened, and I can choose to confront their racism or ignore it. I can pretend that health disparities don't affect me or my family without acknowledging that we accrue benefits from a system that systematically favors our skin color. So I just want to pause right there and just ask you to reflect, whether you are a clinician,
Dr. Peterson, I don't know if you could hear me. Your sound is cutting in and out a little bit. I apologize.
and the need to address systems of privilege in order to mitigate, to help decrease the health disparities, the oppression, and the trauma that happens to Black folks. So next I want to talk about recognizing racial trauma in patient care and how important that is. So we've been hearing a lot of talk lately about microaggressions, and they are racism-related experience that can range from frequent smaller aggressions, and it's microaggressions in quotes because is it really small? But you'll see that as we talk more. But we also look at blatant hate crimes and physical assault, and those are things that people tend to focus on when we talk about racism, right? But microaggressions are also a trigger for racial stress. These microaggressions are subtle, yet pervasive. They can be brief remarks that someone says, or vague insults, even nonverbal exchanges such as funny look, refusal to sit next to the person, being followed by security guards in a store, and seeing a white woman clutch her purse in an elevator when a Black man enters. When experiencing microaggressions, the person who's the target, the Black person, loses vital mental resources trying to figure out the intention of the one committing the act. These events may happen frequently, making it difficult to mentally manage the volume of racial stressors. The unpredictability and anxiety-provoking nature can lead victims feeling like they're going crazy. Like, am I crazy? Did they just infer? Black people with higher levels of education, socioeconomic status, and positions in organizations may experience more discrimination because they threaten the social order and thus draw increased hate from others. And that just speaks to the idea that you cannot out-earn racism or overeducate and escape racism. It actually increases as those things occur. So assessing and treating racial trauma. It's important to note that once a patient is sensitized through ongoing racism, even microaggressions or routine slights can have an increasingly greater toll. And chronic fear of these experiences can actually lead to constant vigilance, may result in traumatization, and can contribute to post-traumatic stress disorder. And I think that's important for us to note because we do see a high rate of anxiety in a lot of our Black patients. And it's important to recognize it and to address it. Small acts of racism need to become unacceptable in our society. And we need those who witness racism to speak out and to believe those who have experienced racism. Healthcare providers also need to be aware of racial trauma and be aware of psychologists, therapists, counselors who can address race-related stress. Not everyone is experienced or educated on dealing with racial trauma, and there is little worse than a patient who has experienced racial trauma and is suffering from race-related trauma and anxiety to be sent to a therapist who does not understand race-related stress and does not acknowledge it. It's just more traumatizing. There is a professor in Philadelphia, Dr. Kenneth Hardy, who looked at the wounds that are caused by racial oppression, particularly in young people. And those wounds were internalized devaluation, assaulted sense of self, internalized voicelessness. Internalized devaluation. Thought I skipped one. Internalized devaluation is a direct byproduct of racism, and it's linked to white supremacy, this deification of whiteness, normalization of all that is white, and demonization of
Dr. Peterson, just a heads up, your mic went out again.
of the uneasiness of devaluation. And in his research, Dr. Hardy found that young people who have internalized devaluation put such a high stake in respect that some would even prefer death than to feeling the disrespect that is heightened because of their internalized evaluation. And then assaulted sense of self is the culmination of recurring experiences of this devaluation. It shapes how people see themselves. It becomes very challenging to have a healthy sense of self when one is inundated with repeated race-related messages, such as you're not as attractive as, or you're not as smart as, you're too dumb to, or you're not intelligent enough to, you're not college material, or maybe you should think about going to something else besides sin. You're not welcomed here. We're just being made to feel that way. The onslaught of devaluing messages makes it hard for the person to know who they really are. And, you know, adolescence is a stage where youth are forming their identities, and it's one of the most vulnerable stages of the life cycle. But also, you know, young people, older people, all of us, when receiving repeated messages that are devaluing, it can increase our sense of, decrease our sense of self.
And this can lead to internalized voicelessness. This is the inability to defend against unwelcome and unjustified negative messages. And it's experienced in systemic and interconnected ways. For example, voicelessness is both a result from, but also fuels internalized evaluation and assaulted sense of self. So while voicelessness does not literally render a person silent, it can impair their ability to advocate for themselves. And then lastly, the wound of rage. And this is the notion that perpetual negative and debilitating messages and having one's sense of self assaulted will eventually develop into rage. Rage can be a deep-seated emotional response to experiences of degradation and devaluation. It builds over time and is very complex. And rage, when we typically think about rage, we think about anger and explosiveness, but it can also be demonstrated in sadness and depression. And so that's very important for clinicians to recognize in their Black patients that this can be a result of race-related stress. And if it's not recognized, interventions can be given incorrectly, right? They could be prescribed anger management interventions when they really need to address the root from the hidden wound of racial oppression. And if that doesn't get addressed, it just can cause more trauma. And then addressing anti-Blackness in medicine. So Angela Davis famously said, in a racist society, it's not enough to be non-racist, we must be anti-racist. So that pertains to medicine, right? In our medical community, it's not enough to be non-racist, we must be anti-racist. Dr. Ibram X. Kendi has a book that's out that's very popular, How to Be an Anti-Racist, and he says the opposite of racist is not racist, it's anti-racist. That action is collection of anti-racist policies that lead to racial equity and are held up by those who are anti-racist. And racism and racists are those who support those racist policies that uphold those ideas and further health disparities. These are just some ways to heal wounds of racial trauma. They are ways that a psychologist or a therapist could assist a patient, but also things that all clinicians should recognize as important because there are some aspects that can come up in any stage of care. So those steps are affirmation and acknowledgement. So when you take care of Black patients, you want to make sure that you understand and accept the premise that race is a critical organizing principle in society, and that just that affirmation and acknowledgement can do so much towards the healing. And it can allow conversations about race to emerge, but also allow patients to have a safe space, to know that their clinician is not going to deny or, just tell them racism is not really an issue, they shouldn't feel that way, and not acknowledge and validate their feelings. And it's important that they be able to share their stories, help them develop their voice, combat that voicelessness that occurs. Some questions that can help them is, can you tell me a story about the first time you realized you were treated differently because of your race? Can you tell me a time when someone attempted to value you based on your race? Can you tell me a time when you felt proud to be Black? And validation just is the confirmation of the person's worldview. And it also involves discovering strengths and qualities of that person and their own ability to fight and rise above, the good things about themselves that may have been overshadowed by stereotyping, pathologizing, demonizing, and criminalizing. Naming, it's really important that we attach words to racially based experiences to help those who are oppressed to be able to communicate and describe, and it goes towards their healing. And then this step is about externalizing devaluation, so understanding why respect and the absence of respect are so important, and to help them to realize that assaults on their dignity do not lessen their own self-worth, that is that other person's problem, and also to counteract devaluation, so provide resources that help build their strengths and buffer against assaults. And lastly, rechanneling rage. Rage is a normal and predictable response to these perpetual experiences, and there's a strong relationship between voicelessness and rage. So the goal of the treatment is not to help them get rid of rage, but help them to be aware of it, to gain control of it, and ultimately to redirect it. And that can help them to have more positive outcomes of healing. Likewise, there's a critical consciousness of anti-Black racism that notes that it's very important to help Black folks as they witness anti-Black racism, to help them process it, and very importantly, to act critically against it. Examples of resistance could be encouraging agencies to collect data that allows us to study the impact of, for instance, the pandemic on Black women and help to identify solutions. They can volunteer and donate to organizations that are addressing anti-Blackness in healthcare, such as in Philadelphia, Dr. Ayla Stanford has started the Black Doctors COVID-19 Consortium, which addresses that disparity in testing in Black communities. They can protest and support grassroots efforts promoting human rights for Black women and LGBTQ. And also, very importantly, they should know their rights as human beings, and also have advocates. In maternal care, I am a great advocate for doulas who can support pregnant women. Healthcare providers need to explore their own biases, identify and acknowledge their own experience of white privilege as individuals, and also as society as a whole. Awareness is the first step, but you can't stop there. We also need to develop a shared language across disciplines and institutions so that we all can address racism and privilege, because it's multi-sectoral, right? So we need to work together and collaborate to combat anti-Blackness and discrimination. And this can look like trainings, workshops, didactic lectures, group discussions, but we must continuously dedicate ourselves to ending the pervasive racism and impact of anti-Blackness in the medical community. This again goes through some of those steps, dealing first with your own individual mindset and biases, how you treat your patients, creating a space for them, going and acknowledging the other levels of racism, organizational structures, and making a commitment to actually develop an action plan to dismantle policies and practices that perpetuate systems of oppression. These are just some questions that you can ask yourself. How am I perpetuating systemic inequities? What are my practices for checking myself? How can we acknowledge the racism within us without making a character judgment that precludes behavior change? How can I be held accountable? What relationships can I develop to help me to realign with my values? And it's important that we know that a lot of times we focus on the interpersonal, but what we really need to put a lot of focus on is the ideological and the institutional. So what beliefs do we hold about healthcare, and what beliefs do we hold about Black people, and how does that affect their healthcare? And institutional, so what rules, policies, or structures have we put in place to support those beliefs? And we really need to address them at that level. Address ongoing and systemic racism in our organizations, but if you don't address whiteness, white ideology, white privilege, you're just going to perpetuate problematic practices. And we also have to note that we have to address anti-Blackness in medical education. Many medical schools have taken steps to include diversity, equity, and inclusion in their curricula, but it's going to take more than these isolated efforts, like a lecture on cultural competency, to address the problem of racial bias in healthcare. We actually need a paradigm shift. We need new education that's actively anti-racist and emphasizes that race is not a biological phenomenon, but a social construct, and it impacts the health of our patients. And we need to focus not just on recruitment, but also retention with an anti-racist lens through not only medical school, but residency training. And lastly, how do we heal ourselves, those who are Black persons who do experience this racialized trauma? We need to develop plans for self-care, and that includes a wellness plan, wellness plan that everyone should follow, right? Adequate sleep, nutritious meals, exercise, 30 minutes a day for 5 days a week. But also be able to practice recognizing when and how to rest, de-stress, expose injustice, might not be the time, might be the time, and when to advocate for your own needs and those of others. Continue spiritual practices that uplift you. It might be church, meditating on scriptures, gospel music, yoga, listening, prayers, anything that increases your resiliency. Work with a therapist, talk, use journaling, artwork, and check in with your body. If there's tension, stress, or pain, stress can be released by resting, deep breathing, and physical activities. And also important is collective care. So stay connected to the community, learn and engage in ways that build resilience across generations, foster healthy relationships and communities that are a sanctuary offering protection from the wounds of racism, create space where friends can openly share their pain without being shamed, and can receive love and support and validation. Get involved in empowering activism. When I spoke to family and friends who have experienced trauma in medicine, and when I asked them, well, what helped you get through that? What decreased your stress and your trauma? And they all would say, advocating, taking steps, addressing the issue head on, not just accepting how they were being treated, calling it out, and seeing some action come as a result. And lastly, but very importantly, continue to create joy. Be intentional about it in your own life individually and as a collective community. And that's how we can address the impacts of anti-Blackness and racism. I want to thank you all for your attention and your time and your intention. And, as we go forth, I'm going to take some questions, and I would just really implore all of us to think about these issues and how we can individually and collectively address the health disparities and the impact of anti-Blackness in medicine. So thank you very much.
Dr. Peterson, thank you for that excellent presentation. There's a lot to take away from it, and our audience members had a lot of questions, very robust questions. So if you don't mind, I will read off some of them for you.
Sure.
We have a good starter question. What is being done or can be done in medical schools to expose students to these issues before they begin to practice in the profession?
That's a great question, and I think it's an area that is often overlooked, and a very important area that we can address. In my own medical training, I did medical school and internship in Philadelphia, and there were times where we talked about disparities and having cultural competency, but there's such a great need. And as I said, you know, there are these one day opportunities to discuss that students are given, right? But it should be, if we really want to address these issues and we understand how racism and anti-Blackness is so ingrained in our society, in our structures, in our institutions, and it affects the health of our patients, then we have to ingrain this information into our education, our medical education. It is not lost on me that many medical students, when they look for training, look to gain training in communities that have huge health disparities, impoverished communities of color, because they will get exposed to a lot of various disorders and diseases. And those institutions who see these high numbers of disparities and have these issues really need to make sure that the medical students who come in as residents have an understanding of what their patients are facing, and not just on a level of social determinants of health, but the racism that keeps that in place, and how to care for these patients and address, you know, at some point, whether it's during their training or as attendings and clinicians out in private practice in the community, we need everyone on board to address these issues. And medical school is a great place to start. It's I cannot say that more. It's a great question, and something that really needs to be addressed. It just needs to be pushed. So those who are in academic medicine and who are exposed and have that ability to directly influence the curriculum have to really address it. It has to also become important to our greater societies and our board certifying organizations. It has to be important that our clinicians are competent, not just in physical diagnosing and assessing and treating physical ailments, but recognizing racial trauma and addressing the issues in our society that increase that in our patients. So important. Yeah, great question.
Thank you for that wonderful answer. We have a few more. We have actually a number more great questions, and I hope we can get to as many as possible.
Okay.
The next one starts off with contextualizing the question. A recent study showed that Black newborn babies in the United States are more likely to survive childbirth if they are cared for by Black doctors, but 3 times more likely than white babies to die when looked after by white doctors. Black women also have maternal mortality rates 3 times that of white women. What are some ways alternative or alternative options that Black people specifically can explore to ensure a safe, affirming, and healthy birthing process?
Mm. Well, you know, that's my wheelhouse and a very important area for me. I did see that research article about Black infants being 3 times more likely to die if their care provider was white than if they were Black, and the call for more physicians of color, more Black physicians, to be able to help to mitigate that, and also awareness on the part of white providers of their own implicit bias and how it can affect care and survival of these infants. And likewise with Black women, many Black women have been traumatized in our medical care system. I talked about, you know, the effects of racial oppression and the fear that it can generate. And in my work, I come across so many Black women who are actually afraid of childbirth, or more so childbirth in the hospitals, and the care that they will receive. Many have felt disrespected during their birthing process. And that anxiety is not good for the mother, it's not good for the baby, it's not good for childbirth, for recovery. So we do need to address anti-Blackness in maternity care. It's really important. Some of the ways that we can address it are individualized, right? So we need more Black birth workers. And when I say birth workers, I'm talking OBGYNs, nurses, doulas, lactation consultants, the whole gamut. We need more Black folks who are caring for these patients, one, because studies show they provide better care overall for Black patients, but also it decreases the anxiety that Black patients feel when they come into an institution and they see providers who look like them. That is very, very important. I think also increasing the number of Black providers will change the ideologies and the focus in these institutions when you have more Black folks at the table helping to develop policies and procedures that can, and also white providers who have an anti-racist focus, right? And one of the ideas of white providers having an anti-racist focus is that they would elevate the voice of Black providers and also push for more Black providers. Also, there are other ways that Black moms can decrease their anxiety and find affirmation and community. I'm a big advocate, as I said, for doulas. There are programs in Philadelphia that can provide free doulas for those who wish to have support during their pregnancy, during their labor, during the postpartum period. Maternity Care Coalition is a wonderful organization that I have worked with that can provide that. There's also psychologists and therapists who specialize in reproductive psychotherapy that can help moms and birthing persons deal with the anxieties that can arise around pregnancy for any birthing person, or those who are also dealing with racialized trauma and reproductive injustice. So in Philadelphia, there is Oshun Center therapist McNeil, who specializes in that. And so I have referred some moms who are dealing with that type of anxiety to her. Developing communities themselves, reaching out. There are groups on Facebook and IG and that support each other. It's difficult now, right, with COVID for people to get together in person, but you can still do groups on Zoom and support and encourage each other, but just really reaching out. And if those who are not birthing persons can also do things to support that community and reach out and do so. But it is very important that we address the anti-Blackness in maternity care.
Wonderful. Thank you for not just abstract advice, but also really concrete resources. I really appreciate that. Thank you. And our audience always loves being directed towards resources. So thank you for that. We have another really great question. How can social workers and physicians work better together to address health disparities, racism, and anti-Blackness in many of these organizations, hospitals, etc.?
I love that question because I've seen it happen, and there definitely needs to be more of it. During my intern year, one of my rotations was actually on the maternity ward, and it dealt with meetings. We would have daily meetings between the social worker, the doctors, and the nurses to come up with a plan for each individual patient that looked at not just that patient's physical concerns, but looked at all of the areas of that person's life. So the social determinants of health, right? Are they going to have food when they go home? Are they in a interpersonal violence situation? What support do they need? And it demonstrated the interconnectedness of all of these areas of a person's life in their healthcare. And it's something that I would love to see replicated throughout medicine, everywhere, and all institutions, right? We have to come at these issues across disciplines, and to also remember to come from an anti-racist lens, because those situations can also be problematic, right? If you have, I'm thinking of situations in which a social worker might be aware of a history of a patient and inform a physician, and then that physician then has a bias towards that patient, right? So we don't want that to happen. And if we come from an anti-racist lens, a trauma-informed lens, being aware that we can, in fact, in how we provide or do not provide care, inflict even more trauma. We have to always keep that in mind, but there needs to be that cross-disciplinary addressing of issues in all organizations at every level. We cannot just focus on one area and think that we're going to make a dramatic change in these disparities.
Thank you for that. Yeah, absolutely. I think integrating an anti-racist framework and lens, no matter what the profession, goes beyond medicine. And as a social worker, I really appreciate that advice.
Mm-hmm.
So we have a few more, we actually have a number of questions. And to our audience, thank you so much for being engaged and active. I apologize if we cannot get to all the questions. Let me see what we have here. There's so many good ones. How do you suggest someone who isn't in a position of power, example, medical scribe, in the workplace, to bring attention to someone who is in a higher position, example, physician, who is demonstrating racist judgments towards a patient?
Ooh, that's a good one. Because oftentimes, especially in those positions, powers of dynamics of power can be very intimidating. And it differs, right, between persons. You know, how you might approach one clinician might be different than how you could approach another. You know, it depends on their own stance and where they are. If you know that this physician is actively trying to be anti-racist and work from that framework, then you can be straightforward with them, right? Let's talk about these issues and how they're showing up in the clinic. But if you're starting with someone who is just not aware at all, they believe they're colorblind, and they are a very authoritative person, you have to approach it a little differently. And that's hard to say, how to approach each person. But if you have a person who is like that, you can kind of approach it in more of a general way. You can talk about things that you're reading. You can talk about experiences that you've had, ways in which you're growing. Even suggestions on if there are like group meetings where you have discussions on topics, throwing that out as a topic for someone to discuss. Just coming up with ideas to continue to put that at the forefront until it becomes normalized. I read a quote yesterday that said, unpacking anti-Blackness needs to be done every single day. And this was an educator talking about dealing with students in schools, but I think it also pertains to medicine, right? We have to think about that with each patient encounter that we have. How am I showing up here? How are my biases showing up here? And how has this person experienced trauma that is affecting them? So yeah, it's a great question and something to be really thoughtful about, but to not remain voiceless, because that can cause its own trauma, right? We need to be more vocal, just finding smart ways to do it.
Absolutely. Thank you for that. And once again, everyone, thank you for these wonderful questions. Before I ask for your closing thoughts and before we kind of close out, I just want to share a really powerful testimony that someone shared. They said, "Thank you, Dr. Peterson, for this presentation. I had that experience of being told that I was not grad school material by a white professor who was also my advisor, who refused to provide me with a recommendation for graduate studies. That interaction impacted my self-esteem and confidence on many levels and for many years. Working through those types of messaging was very difficult when faced with different forms of racism daily. I'm forever thankful for those who have fought for me to have access and for my own determination to defy the odds to now be in a position to support others who look like me."
Oh, wonderful, wonderful. Thank you for sharing that. It's so prevalent. I cannot tell you the amount of students. My husband works at a university, and so we often talk about the intersection of education and medical care and the anti-Blackness that shows up in both of those areas, and how they intersect, and how important it is for us to address these issues. But so many Black professionals that I have spoken to have had that exact experience from high school, their guidance counselor telling them not to shoot for the top schools, to professors telling them to drop the course because, you know, they weren't capable. And they needed to dig deep and find resources within themselves and within their community, and could push through it. But just imagine all of the Black professionals that we do have, if they didn't have the resiliency, the self-care, the collective care, how many times along the way they would have been discouraged. And so it's wonderful to hear stories like that, to encourage others who are experiencing it, that they're not alone, that they're not quote unquote crazy. This is really happening. This anti-Blackness experience is showing up for them in their educational process. And it's so important that they advocate for themselves and find others who can advocate for them and support them and encourage them. And so they can hear other stories of resiliency and triumph. So thank you so much for sharing that.
And thank you, Dr. Peterson. It looks like we're coming just about up on time. So before I give my little closing out speech, is there anything you would like to leave our audience with today?
I am just overwhelmed and actually very excited about the engagement, and I wish I had more time to answer any questions. If anyone wants to reach out to me individually, my email is on the screen. I'd be more than happy to hear your stories, answer your questions, provide any resources that I might have, or work with you to address these issues in our community. So, and thank you. Thank you so much. Thank you all.
Thank you, Dr. Peterson. And to everyone who joined us today and stayed with us to the very end, just as this webinar closes out, you will be prompted to take a survey. Once again, just let us know how we're doing. The webinar is recorded and will be available on YouTube after the airing of this webinar. And also just take care of yourselves. You know, this is really difficult work to do, and just be kind to yourself and be kind to others. And I hope you all enjoy the rest of your week and come back next week as we continue this conversation, as we address racism and mass incarceration, as well as faith. So thank you so much and have a good one. Take care.